Hi, and thank you very much for inviting me to speak today about our project on post-discharge sepsis survival and hospital-specific inpatient mortality. I'll start by mentioning that while I have no disclosures, the data used for this study was provided through grant funding from both the Agency for Healthcare Research and Quality and the NHLBI. As many may be aware, sepsis is a life-threatening condition that affects over 1.5 million Americans each year, with an inpatient mortality rate of approximately 16%. As shown in a study by Ree and colleagues, this was true even while the incidence of sepsis cases continued to hold steady or even increase in recent years. This improvement in outcomes may be attributable to early aggressive clinical care, but in-hospital mortality varies significantly. Volume, location, and teaching status may all be associated with variability in outcomes. However, the burden of sepsis continues for those who survive their initial hospitalization. Sepsis survivors were frequently readmitted, 21% within 30 days, and Prescott et al. Found that compared with a number of matched cohorts, sepsis patients had an increase in absolute mortality that ranged from 10 to 22%. Whether or not factors related to the increase in mortality are modifiable remains in question. Therefore, we sought to determine the relationship between the quality of care delivered during the index hospitalization for sepsis and post-discharge outcomes. Specifically, we wanted to determine if facility-level inpatient mortality for sepsis, as measured by observed to expected ratios, was associated with mortality, readmissions, and skilled nursing facility discharge. We hypothesized that hospitals that provide higher quality care would have improved post-discharge outcomes, suggesting that the impact of inpatient sepsis treatment extends beyond hospital discharge. We designed a retrospective cohort study of age-qualifying Medicare beneficiaries with an ED-based hospitalization for sepsis or septic shock between January 1, 2013 and December 31, 2014. The Zebrowski definition was used to identify sepsis cases from ICD-9 CM codes. Hospital sepsis quality data from the Early Management Bundle for Severe Sepsis and Septic Shock, otherwise known as SEP1 data, was obtained from CMS as part of their hospital inpatient quality reporting program. For all analyses, only hospitals with at least 200 cases were retained to allow for stability of estimates. Cases were followed for up to 6 months for survival and censored on December 31st, 2014 for readmissions. Deaths and readmissions from any cause were included in our analyses. The primary exposure of interest was hospital-specific mortality for the hospital where the beneficiaries received their definitive sepsis care. Observed to expected mortality ratios were calculated using a risk-adjusted sepsis model that included patient-level predictors, including age, comorbidities, infection source, and organ involvement, among others. The predicted probability was calculated for each sepsis case, then summed for the facility and used to create an O to E ratio with the summed value of the observed deaths for that facility. A second exposure of interest was the hospital's SEP1 performance using the first year's publicly reported and an average score if more than one quarter was available. The primary outcome of interest was 90-day post-discharge mortality, measured as 90 days from the date of hospital discharge for those patients who survived their index hospitalization for sepsis. For our mortality outcomes, hierarchical logistic regression was used with clustering at the hospital level. Covariates include patient and community characteristics such as unemployment, education, and poverty rates. Secondary analyses included Cox proportional hazard models to explore the time to readmission and time to death, and we also estimated an E-value to look at unmeasured confounding. We had approximately 830,000 Medicare beneficiaries with a hospitalization for sepsis during our 2-year study period. Of those, about half were female, a quarter were non-white, and a third were over 85 years old. Respiratory and urinary sources were the most common infection sites. Less than 10% of our population resided in a nursing home prior to their admission. and cumulative mortality was around 35% at 30 days and up to 48% at 180 days. Of the more than 1,500 hospitals that initially treated sepsis patients, the O/E ratios ranged from 0.29 to 2.2. Unadjusted 90-day mortality was 1.08 per 0.1 increase in hospital O/E and dropped to 1.03 in our risk-adjusted models. The magnitude of effect was unchanged over time. In time-to-event models, a dose-response relationship was seen between O/E and survival. The median SEP1 adherence was 47%, although 19% of hospitals did not report a score during the quarters that were analyzed. SEP1 scores predicted mortality at 30 days with an adjusted odds ratio of 1.09, but significant association with mortality did not persist at the later time points. As with mortality, readmissions were associated with higher hospital O/E ratios. 37% of the cohort was readmitted during the 6-month follow-up period, and the median time to readmission among patients that had a readmission was 30 days in hospitals with an O/E greater than 1.25 and 34 days in a hospital with an O/E less than 0.75. Of the over 600,000 beneficiaries who did not reside in a SNF prior to admission, 25% were discharged to a SNF. The odds of being discharged to a SNF were 1.03 for every 0.1 increase in O/E ratio for their treating hospital. And our final analyses was to explore the possibility of unmeasured confounding. We calculated an e-value to determine the odds ratio that would be required for an unmeasured confounder to render our primary findings null. We found that the confounder would need to have an odds of at least 2.05, and that would be similar in magnitude to a cancer diagnosis or pre-sepsis SNF residence. We found that care delivered during the initial hospitalization for sepsis may contribute to outcomes well after hospital discharge. Our measure uses risk-adjusted observed to expected ratios, an established method of evaluating a hospital quality and performance to benchmark sepsis-specific care. And while it can't identify which factors are associated with preventing later mortality, it suggests that the quality of inpatient care delivered as a whole may have a lasting impact. Specific elements of care after initial resuscitation that contribute to long-term survival require further exploration to identify causal relationships. Our study had a number of limitations. First and foremost, unobserved confounding remains a key possibility given our use of observational data. The use of claims-based O/E ratios are likely an incomplete surrogate for hospital quality and have some potential for residual confounding given the limitations of the data from which they were derived. Second, the SEP1 data and the timing of the sepsis cases diverged by 3 years. This mismatch could result in misclassification if facilities significantly improved performance prior to the SEP1 implementation and reporting. However, the earliest publicly reported data was used for the evaluation. Finally, the dataset was limited to age-qualifying Medicare beneficiaries. While 2/3 of sepsis cases fall into this category, there is the possibility that outcomes for the remaining cases could be significantly different due to insurance status, access to care, or other factors we are unable to explore. In conclusion, patients treated at hospitals with increased inpatient survival for sepsis have lower post-discharge mortality, lower readmission rates, and lower rates of discharge to SNF. Some of the factors leading to these outcomes may be modifiable, although future work should focus on identifying the key measures associated with post-discharge outcomes. I'd like to thank my study team, Dr. Brendan Carr, who is also my mentor, Dr. David Gaieski at Thomas Jefferson University, and David Buckler, who helped to create the data sets we used in this analysis. I'd also like to thank Nick Moore, who is a collaborator on this project. Finally, I'd like to thank David Karp and Annie Tang, who helped with the processing of the CMS data, and Danielle Pryor, our research assistant. I'll now take any questions.